May I invite Dr. Vijy Paul next, please?
Good morning, respected chairpersons, senior members, colleagues and friends. A recurrent thyroid swelling is something which, it's a condition which we often are called to attend surgical treatment of a recurrent thyroid nodule. And as was mentioned by Dr. Srijayan, what we come to know is surgery for the thyroid. Primary thyroid surgery itself is a difficult proposition. He talked about the recurrent laryngeal nerve and the parathyroids and all that. And a redo surgery is definitely more of a problem than a primary thyroid surgery. Now, why do we really have to do a reoperative surgery? That is because at one time, it was thought appropriate that a less than total thyroidectomy would be ideal for the treatment of many conditions, whereas over the time, we have now moved more towards an era of total thyroidectomy. So, we would end up having recurrent solitary nodules or multinodular goiters. This would be because either a hemi was done or a subtotal thyroidectomy was done for a benign condition, or when sometimes you have less than total thyroidectomy done and the final histopathology diagnosis comes as malignancy, then you have to do a completion thyroidectomy. Now this debate about total versus subtotal is always there. There still are people who are vocal about subtotal thyroidectomies. But while the total group especially argues in favor of completeness of surgery and easier and more meticulous follow-up in the after malignancies, the subtotal group thinks that it is not worthy to burden your patients with all the complications of a total thyroidectomy just for the sake of completion of surgery, whereas they feel that you could actually treat them with a subtotal most of the time, and if at all there is a diagnosis of malignancy, many often you have a papillary microcarcinoma, it's not of much consequence. So this debate goes on. They feel that if at all a recurrence happens, that can be managed with not much of morbidity. Now when you talk about redo surgeries, why is it considered difficult? The difficulty primarily is because of the strong adhesions. There is a fibrotic encasement of the important structures of the neck. The point is, you have the head above, the torso below, everything in the neck is important. So there is hardly anything that you can sacrifice. And when this fibrotic encasement happens because of the scarring and the tissue reaction, a redo surgery in that area is definitely going to be difficult and can cause significant morbidity to your patients. And what are the possible problems that you could end up with? We need to understand that a redo thyroidectomy is not an innocuous procedure. It's associated with almost a 10% complication rate, which about 4% is a permanent complication rate, and that includes hypoparathyroidism and recurrent laryngeal nerve injury, both of which are absolutely distressing for the patient to carry on for the rest of his or her life. And surgical experience and good knowledge of the anatomical variations of the recurrent laryngeal nerve and parathyroid glands, as was described now, is particularly important to handle this kind of condition. Now, to know what exactly to expect when we do redo thyroidectomy, I spoke to a couple of very senior surgeons who were operating much in the era of subtotal as well as now. And some of the contributions they gave was, one is that there is use of catgut as suture material was very common at that time, and that would lead to a severe inflammatory reaction, which would then translate into a lot of scarring. And you would expect that these patients had undergone many subtotal or sometimes just a lobectomy or even a hemithyroidectomy. So that would be the residue that you would be operating about. And the use of monopolar cautery. Monopolar cautery was particularly used at that time, more in these cases. And so what would happen is there would be a tissue damage which is slightly more than the area in which it was used, about 3 to 4 millimeter away from the site where it was used, there would be a tissue reaction. Again, that would lead to scarring. And the adhesion, especially at all planes, there would be adhesions in all planes, and even raising the skin flap itself would be more difficult because of difficulty getting into the subplatysmal plane. Also, I was informed that there was a practice of anchoring the remnant of the trachea the thyroid to the trachea for sake of hemostasis, and that would make it difficult to dissect that area in a redo thyroidectomy. Also, there was the practice of ligation of the inferior thyroid artery in continuity, medial to the nerve, leading to fibrosis, and the nerve would either be caught in the scarring or would be absolutely close to the scar tissue. Also, the previous practice of retaining remnant near the superior pole, so that would be the region of your recurrence, So that would also put the external branch of the superior laryngeal nerve to injury, risk of injury. And if at all the thyrothymic ligament and the pyramidal lobe were overlooked in your previous surgery, what would happen is you could get isolated retrosternal recurrences or recurrences in the pyramidal lobe, which are also very important and should not be missed when a redo thyroidectomy is being planned. So going on to what are the steps for a safe surgery, I've tweaked the presentation a little, no video, just a few steps that I've mentioned. We need to be daring as surgeons, but we need to also remember that a redo thyroidectomy is no child's play. So every recurrent thyroid tissue need not come out from the neck. So you need to choose your patient, which patient actually needs a redo thyroidectomy. Second is, you need to do a direct laryngoscopy for all of these patients, even in the absence of clinical symptoms, not just for medico-legal reasons, but also these patients, if the opposite recurrent laryngeal nerve is already gone, you have a limitation when you're doing your surgery on the ipsilateral side. So that is very important to know the status of the opposite vocal cord, not just for medico-legal reasons. And you have the scar of previous surgery, you could either go through the scar, or if the scar was particularly bad, you could excise the scar. And sometimes, like I just mentioned, the getting into that subplatysmal plane could sometimes be a little difficult, in which case you could extend the incision a little, go into virgin tissue, find the plane and work your way medially. Visualization of the recurrent laryngeal nerve is absolutely mandatory in these patients. This is already mentioned by Dr. Srijayan in terms of primary thyroidectomy. Here it becomes absolutely essential because there is a high risk of injury to the recurrent laryngeal nerve. So you should either identify it in the superior part or in the inferior part and trace the whole course of the nerve even through the scar tissue. There is also a lateral approach to the thyroid described. I was talking about the difficulty of dissecting in the region of the trachea. We could go lateral to the strap muscles and reach directly into the region of the recurrent laryngeal nerve and then work medially towards the anterior, towards the midline. That would also help. Also, the parathyroids need to be preserved, and if devascularized, they need to be transplanted into the sternum mastoid. Now, it's very important because we don't really know the status of the parathyroids on the opposite side, so the parathyroids have to be preserved, and that thing that you are preserving, the last one, that was a good one by Dr. Srijayan. And as a step in early surgery, palpating the opposite lobe when in subtotal or in a hemi was a bad idea. And for hyperthyroidism, you choose your patients. Every patient with hyperthyroidism does not really need to go and have a redo thyroidectomy done. What I was talking about is the nodules in the pyramidal lobe in the primary surgery itself. This is one area which you need to be careful about. And finally, use of energy devices like the harmonic scalpel and what was just talked about in intraoperative nerve monitoring is considered useful. I don't have personal experience with this though. These are all possibly the precautions and the steps that you could take to preserve to have a safe redo thyroidectomy. I would like to thank Dr. Santosh John Abraham for the valuable inputs that he gave, as well as Dr. Nirmalan Raja, my former boss at MOSC, for sharing his thoughts. Thank you very much.
The topic is open for discussion.
Dr. Vijy, will you do any additional investigations before going in for surgery in a recurrent cases, other than a regular ultrasound? Any other investigations?
In this case, the risk actually is about infiltration into surrounding structures. So it is always better to have a plan. Although it's not mandatory, it is suggested that you could also do a contrast CT scan or even an MRI of the neck before you decide on getting on to the actual procedure.
That depends on the pathology at which the primary surgery was done. That's also decided.
Yes.
And most importantly, who did the primary surgery? Our teachers used to say that you have to identify the person who did the surgery first. Because if a person who did the surgery in a meticulous manner, you know that that surgeon is used to do surgery in a definitive way. Sometimes it may be much more difficult for you to redo the surgery there. That's the most important point.
Okay.
You mentioned about going through a new area rather than the previous scar. Is it wise to have two incisions or scars on the neck?
Sir, not separate incision. It's about extending the incision a little to the sides so that you go through virgin plane. It's probably not a good idea to have two separate scars in the neck.
That means you have to go higher than the
Not higher, sir. You extend the lateral end of the incision a little more. That's
you have to widen it.
Widen it, yes.
What about the lateral approach?
The lateral approach, what they described is you go lateral to the strap muscles and you go between the sternomastoid and the strap muscles and you go into that area. And they say it's easier to dissect there.
It may be beneficial for a true recurrence.
True recurrence, yes.
Thank you, sir. I think we'll have to move on.
Thank you.
Thank you very much.